Welcome to The Seasoned Sonographer, the podcast where experience meets education in the world of OB/GYN ultrasound. My name is Lynn Flamm, and I'll be your host. I'm a registered diagnostic medical sonographer with over 32 years of experience, most of that time in OB/GYN ultrasound. Through this podcast, I'm here to share insights, tips, and case studies to help you sharpen your skills and optimize your scans. Whether you're just starting out or you're a seasoned pro, this is the place to grow your knowledge and confidence. Let's dive into today's episode. Welcome, Dr. Torrez, to The Seasoned Sonographer.
Thanks for having me.
Yes, Dr. Torrez is a board-certified OB/GYN, and she's here to talk with us today about biophysical profiles, help us to understand what they are, how the scoring works, and how that ultimately could impact delivery timing. Dr. Torrez, what is a biophysical profile and when do you typically order them?
So biophysical profiles are a part of what we call antenatal testing, or essentially fetal well-being testing. We do antenatal testing in patients to help avoid the risk of stillbirth, okay? Or in other words, when a baby dies inside before a mother giving birth. Now, still, the rate of stillbirth in the normal population is relatively low. It only occurs in about 6.2 per 100 births, but we decide to incorporate antenatal testing in if anybody has a condition that would raise that risk of stillbirth compared to the normal population. And we do that several different ways. So one of the components of checking well-being and fetal well-being is a biophysical profile, also known as a BPP. So examples of certain conditions that would increase that baseline risk of stillbirth would be things like pre-existing type 2 diabetes, preeclampsia, chronic hypertension, and a multitude of other maternal or fetal conditions.
Like fetal growth restriction even?
Yes,
okay.
like fetal growth restriction.
Okay. So I want to walk through the components of the BPP real quick. And as an ultrasonographer, the biophysical profile components are the fetal breathing lasting for 30 seconds, the fetal tone, that's one episode of fetal tone, of flexion and extension, the gross fetal movements, 3 episodes of movement within that 30-minute time period, and then an amniotic fluid pocket measured vertically that's at least 2 centimeters. What does each one of these components mean?
So overall, fetal well-being and these fetal well-being evaluations has to do with a complex interplay between the messages from the brain to the fetal body and body systems in relation to their acid-base status, or whether or not they're receiving good oxygenation through their development. And so most of these things that you see are actually controlled by higher order centers of the brain in response to that system. And so we can kind of break down each of those individual components that you talked about. So one of the components that a ultrasonographer is not responsible for is the fetal non-stress test, which is a component of a full BPP. And so a fetal non-stress test is where we do fetal monitoring with both an external monitor that tracks the fetal heart rate and with something called a tokometer, which helps to detect uterine shape changes and detect contractions. And so in a baby or a fetus that is doing well and is oxygenating well, we will see what we call reactive NST, where for 20 to 40 minutes, we have an excellent fetal strip that shows accelerations. And that's a description of that's for another time in a different podcast.
Right.
But the other components of it have to deal with how that fetus is responding to its environment and responding to oxygenation level. And I'm going to go into just a little bit more detail too than you had even given.
Mm-hmm.
So when speaking about, fetal breathing movements, you said, yes, one episode, more than 30 seconds duration within 30 minutes. One thing to note is that hiccups count.
Yes, they do.
And so in order to, and one thing to note too, when you're assigning a BPP, it's either a score of 2 or nothing. So you have, to be off for breathing, you have complete absent breathing or no sustained episodes. And then is next the body or limb movements. So the 3 discrete body or limb movements in 30 minutes. It can include fine motor movements like rolling movements, but not like REM movements or mouth movements. And so if you have less than 3 of those, you get a 0. Fetal tone or posture. So 1 or more episode of active extension with rapid return to flexion of fetal limbs and brisk repositioning, tuck rotation, opening and closing of the hand, mouth, and kicking. And so it would be 0 if it was low velocity movement only, incomplete flexion, flaccid extremity positions, or if they're completely absent. We did talk about the amniotic fluids, at least the 2 centimeters of the max vertical pocket not containing an umbilical cord.
Right.
Okay.
Or fetal parts.
So the reason why each of these components are important is that if a baby is starting to become compromised, meaning not having good blood flow, not having fetal oxygenation, we will see loss of these different components of a BPP. Typically, although not always, can be lost in a specific anticipated order with worsening status. And so you could start by losing the NST becoming non-reactive. The most common of the components to be a score of 0 is fetal breathing. Now, that's not always worrisome because we talked about how this is controlled by the higher centers of the fetal brain. As a fetus ages, it will start to practice fetal sleep cycles. And so it can be normal to have absent fetal breathing at times or other components. But then they typically will start to fall off as a fetus becomes compromised. So why is all of this testing is important? Well, we do these at set intervals because these tests are very, very good at making sure a baby is doing well. So if you have a normal NST, it has a negative predictive value of 99.8%, meaning the likelihood of having a stillbirth in a week following a normal NST is less than 99.8%. When you do a BPP with that, the likelihood of having a stillbirth in the following week is less than 99.9%. They're very good at predicting, making sure babies are doing well on the inside.
So when you get a score that's less than 8 or 10, if it's 6 or if it's 4, what happens then? What do you do with that score that's not perfect?
Yeah, so it depends on the clinical scenario and it depends on the gestational age. Typically, if we're getting an abnormal score, most patients will be directed towards an OB triage unit or somewhere where we can do more prolonged monitoring. And so it depends on the full clinical picture. But what we do definitely depends on what the score is and the gestational age at which it is occurring. Okay. So if you are a term delivery, so term meaning a gestational age of greater than 37 weeks, and we get a score of 6 out of 8 or less, or if we have suddenly oligohydramnios that is persistent, we would recommend delivery. If we are in certain instances, now, medicine has lots of different factors to it, but these are, typical
all the pieces of the puzzle
Correct.
are pertinent.
If a patient is preterm, less than 37 weeks, we talked about how this can be a dynamic testing. A lot of times the recommendation would be to immediately repeat the BPP within 4 to 6 hours to make sure that it's still valid. And then doing observation and potentially, if it's 6 out of 8 and you're preterm, repeating it in 24 hours, and if it is still abnormal, considering moving to delivery. If it is 4 out of 10, and we are preterm, we would, again, kind of repeat the same process with immediately repeating the BPP and considering delivery if it's still abnormal. If you have a 2 out of 10, one, you're supposed to prolong the amount of time that you are observing them. You can do it up to 120 minutes, but if it's still abnormal, it's recommended for immediate delivery. And so antenatal testing really does affect our delivery timing, as they are, good measures for fetal well-being. The thing that is difficult in this conversation, though, is that although they're really good at making sure, if they're negative, that bad things aren't going to happen, you sometimes have false positives like any other test. And so that's why we tend to look at the entire clinical scenario as well as what repeat testing is.
Right. And then, so what about isolated oligohydramnios or polyhydramnios when the biophysical profile is a normal score? Those, like you said, you just kind of follow up on, repeat the test, or put them on the NST, or
it depends. Those are two, kind of different scenarios. Let's look at oligohydramnios, meaning too low of fluid, meaning a max vertical pocket less than 2 centimeters without a cord in it. So the number one thing that we do when we see low fluid is we make sure we rule out other reasons for low fluid, okay? We're going to make sure that our anatomy ultrasound had nothing concerning for an obstruction of the urogenital tract at all. And then we're also going to make sure that someone didn't asymptomatically have pre-labor rupture of their membranes, which would account for low fluid. Okay, so we do a full workup for that, making sure we're not missing that. If those are negative and you have isolated low fluid, that can be concerning for placental insufficiency, meaning the placenta not working as well as it could be. The placenta is where baby gets its blood supply. And so if that blood supply is starting to be compromised, sometimes that compromise is shown to us by the the fluid within becoming lower, because the vast majority of amniotic fluid is actually fetal urine. And fetal urine is produced by having good blood flow to the fetal kidneys. And if that blood flow is becoming abnormal and we don't have another and the fluid is getting low, we don't have another etiology for it, we have to assume that it has to deal with how well the placenta is functioning. So even if we have a completely normal biophysical profile, if we have isolated and persistent low fluid without other etiology, it would necessitate an earlier delivery and more intensive fetal surveillance, depending at the gestational age at which it's diagnosed. Now, for too much fluid, polyhydramnios, there's lots of different things that can cause polyhydramnios. And so if we see just a normal BPP and, isolated mild polyhydramnios, we actually really don't change much in that scenario. They're still already getting antenatal testing. The only thing that would change in polyhydramnios is if you were to have moderate or severe polyhydramnios and you weren't already getting antenatal testing, because moderate to severe polyhydramnios is an indication for antenatal testing.
And that's greater than 30 centimeters?
Yes, greater than 30 centimeters for the AFI.
So that's when that would trigger the BPP.
Correct. Or an NST, and obviously a workup for the etiology for polyhydramnios.
Okay, so the biophysical profile is a good predictor for placental insufficiency, but how do we know when to maybe add an umbilical artery Doppler to enhance that?
Correct. So umbilical artery Dopplers, or studies that show the velocity through the umbilical cord, are only indicated in the setting for fetal growth restriction.
Okay.
So fetal growth restriction, which we diagnose on our growth ultrasounds, diagnosed as either an estimated fetal weight less than the 10th percentile or an abdominal circumference less than the 10th percentile. There are lots of different etiologies that can cause growth restriction, but one of the ones that are concerning is placental insufficiency. As we discussed previously, when we were discussing low fluid, if the blood flow starts being compromised to the baby won't grow as well. And so that's why we add those studies on, demonstrating, is there any sort of resistance in the cord causing that issue? Now, the reason why that gets added on in addition to a BPP is it really does affect our delivery timing, okay? So if you have a uncomplicated, isolated, non-severe fetal growth restriction, delivery timing for that is quite large. It's, 38.0 to 39.6. Now, if you have that plus elevated umbilical artery Dopplers, you would decrease that delivery timing to about 37 weeks. And keeping with our theme for antenatal testing, this is all about, risk of stillbirth and making sure our testing is catching risk of stillbirth. The addition of umbilical artery Dopplers, changing the delivery timing, is that our ability to predict fetal compromise decreases in the setting of abnormal umbilical artery Dopplers. And so if you had a growth restricted baby that was non-severe, and you had a BPP that was, 10 out of 10, but all of a sudden we have intermittent absent and diastolic flow, that would necessitate admission and an earlier delivery than even 37 weeks, because that baby is more likely to suffer more rapid deterioration potentially. And so that's where we add the umbilical artery Doppler.
And then if there's reversed in diastolic flow, that would be immediate delivery, right?
That is a difficult question. It depends on multiple factors. Okay. It depends on the gestational age at which it occurred. It depends on the growth of baby. It depends on whether or not that baby has undergone antenatal steroids. But typically speaking, when we see reverse end diastolic flow, it would precipitate a more rapid move towards delivery.
So at what point in time would you want the sonographer, when we're doing the biophysical profile, when would you want the sonographer to come and get you, or to raise the red flag to you, come out of the room and let you know that something is not right?
So in terms of the BPP, so one, if you have any concern that you're near like a 2 or lower on your BPP, where right, baby is just not moving, if you're concerned that you're seeing no fluid there, for Doppler flows, definitely if you feel like you are seeing absent or reversed flow on the Doppler, making your physician aware. And then always making sure that we are, calculating our elevated Dopplers based on gestational age, right, and just making them aware that you saw elevated cord Dopplers, or making sure that if you're seeing absent flow, that you let us know. Is it intermittent? Is it all the time? Same thing with reversed.
What is your advice for sonographers trying to reassure those anxious patients without giving them any false information or without giving them diagnosis? Because we're in the room for up to 30 minutes with these patients, and sometimes things aren't going well. And so how would you suggest we handle those situations? And then how do you tell patients, how do you counsel patients for abnormal BPPs?
So my best advice would be to reassure patients that we're doing fetal well-being checks for a reason, but it's okay for them to be abnormal at times, because it's not a perfect test. It is a test that's really good if it's perfect. The likelihood of having something bad happen with a perfect test is very, very low. But having an imperfect test doesn't actually necessarily mean anything's going on. So it remains in like the clinical context of the situation.
Right.
Reminding patients that, it's as we get more neurologically developed, we're more likely to sometimes have a slightly abnormal BPP because we are practicing those fetal sleep cycles. Letting patients know that we're getting a snapshot in time. And in the same way that you and I are dynamic, babies are dynamic too sometimes. And sometimes they'll, for whatever reason, not have that full BPP score, or what we call an equivocal BPP score. And then we go to immediately repeat it, and it's perfectly normal again. And that it's the art of medicine. It's not perfect science, and it needs just to be taken in context.
What about one key takeaway for sonographers when performing the BPPs and reporting, and maybe even like what do you feel must be in the report?
So, all components must be in the report. Making sure that you're really seeing the things that you're seeing, just because it is so important for fetal well-being. Making sure that we're using our correct terminology when it comes to the fluid. It really is, that deepest vertical pocket without a cord in it, not necessarily the AFI. And just making sure that you're aware of your time and looking for those movements as you need them. And also with the knowledge of report what it is. We have things in place where if it's abnormal, we repeat it. We are not going to, we do make decisions based on these tests, but you shouldn't have fear of reporting them because you're going to be, your interpretation of them may be wrong. We have fail-safes for that.
Well, is there anything else you'd like to let us know about biophysical profiles? It seems like you were very thorough.
Well, thank you. But no, they're just, they're an adjunct tool.
Yes.
They're never an end-all, be-all. They're used in clinical context. And so they're important. They're important means for preventing a very serious outcome, but they're very nuanced. And it's all a part of the art that is medicine, and that all of us are practicing to use them in the scenarios that we see them and that we need them for.
Today, we've highlighted how the biophysical profile gives us a window into the fetal well-being, from breathing and tone to amniotic fluid and Dopplers. It's a simple but powerful tool that helps guide decision-making and protect both moms and babies. Dr. Torrez, thank you so much for joining me today and sharing your expertise.
Thank you so much for your time. I really appreciate it.
Yeah, not a problem.
Thank you so much for joining me for this episode of The Seasoned Sonographer. If you're interested in improving your OBGYN ultrasound skills and learning more about the field, make sure to subscribe to The Seasoned Sonographer on Apple Podcasts, Spotify, and YouTube. You don't want to miss any of the upcoming episodes. You can also connect with me on Facebook and Instagram at Sonotechniques Academy. Explore more educational resources on the Sonotechniques Academy app, or reach out via email, lynn@sonotechniquesacademy.com. I'd love to hear from you. If you have questions or topics you'd like for me to cover, feel free to reach out. This podcast is for you, and I want to make sure I'm covering the topics that matter most to you and to the ultrasound community. Until next time, keep striving for excellence in your scans, and I'll see you in the next episode of The Seasoned Sonographer. The information provided in this podcast and any accompanying materials is for educational and informational purposes only. It is not intended as a substitute for professional medical advice.